Okay, this is the Chapter 23 Respiratory System lecture. This one is pretty large, it's about 155 slides, so it will be split into two different ones. I'm going to get through about 70-ish slides on this one, and then I'll upload another video with the rest. So the respiratory system is for gas exchange, oxygen for carbon dioxide. It occurs between the atmosphere and the body cells. We'll see we have both external and internal respiration. Cells need oxygen for aerobic ATP production, and they need to dispose of carbon dioxide that process produces. Aerobic respiration is going to be making a lot more ATP, much more regenerative, and our muscles produce CO2 as waste. Our cells do. Respiratory system provides a means for that gas exchange, has respiratory passageways in the head, neck, and trunk, and the lungs. The air passageways moves between the atmosphere and the alveoli as we breathe. They are the main site for gas exchange of oxygen and carbon dioxide. You have oxygen diffusing from the alveoli into the blood, and carbon dioxide diffusing from the blood into the alveoli. It also adds for detection of odors, olfactory receptors in the superior nasal cavity, just below that olfactory plate. You have sound production as well, air moving across the vocal cords of larynx. The vocal cords vibrate, producing sound, as well as the sinuses and the cranium. They are hollow passageways that allow for sound amplification. We'll get into all of these processes much more, hopefully as in depth as you want to. Hopefully you want to learn this. Okay, we can organize it structurally. You have the upper and lower respiratory tracts. The upper respiratory tract runs from your nose to your pharynx, so from your nostrils to your throat. And then the lower respiratory tract goes from the larynx, your voice box, the trachea, bronchi, all the way down to your alveoli, which are the functional units of your lungs. They actually make up what your lungs are. We can look at it functionally. We have the conducting zone and the respiratory zone. The conducting zone is exactly what you think it sounds like. It's transporting air, it's conducting and moving air down. It goes from the nose to the terminal bronchioles, whereas the respiratory zone is where it's actually going to be participating in gas exchange. That is just the respiratory bronchioles to the alveoli, so just the very bottom portion of the system. Here is just broken down for you. Okay, looking at the respiratory mucosa, that respiratory lining. So the mucosa is the mucous membrane. It lines the respiratory tract. It's an epithelium resting on a basement membrane that helps to connect it to the structures. Underlying lamina propria made of areolar connective tissue, so it has space to be able to produce this mucus. The respiratory epithelium becomes thinner from the nasal cavity to the alveoli, so as you go down the respiratory tract, your epithelium is getting thinner, as well as less ciliated. It starts off as pseudostratified ciliated columnar in your nose and nasal cavity, pretty much down to your bronchioles, and then it starts to change into simple ciliated, simple cuboidal, simple squamous. The exceptions are going to be stratified squamous in the high abrasion areas around the vocal cords, and in the pharynx and your throat where you're swallowing, chewing, eating things. If you don't remember your epithelial tissue, you have your pseudostratified, so that is what's going to look like it's stacked on top of itself, but it's not, or stacked on top of each other, but it's not. It's ciliated, so it has the hairs that's going to help to sweep particulate matter down the respiratory membrane or across the respiratory membrane. And then columnar is just a shape, it's those columns. As you start to go from pseudostratified to simple is just that one layer, still ciliated, still columnar. Then we start to get into simple cuboidal. Notice it's no longer ciliated, and it's in these little tiny square shapes. And eventually going to simple squamous, which is much flatter. That's going to be right at the alveolar ducts and alveolar membrane for allowing gas exchange. Here you can see goblet cells sitting within the epithelium. There's that basement membrane that's attaching it to the lamina propria underneath it with blood vessels in there. And this mucous membrane, this layer of mucus that the goblet cells are producing. This is will help you in your lab, actually. There's a question in lab about the layers of the respiratory tract, of the respiratory membrane. So you can just kind of see as it goes down, it gets thinner and thinner, eventually becoming this simple squamous epithelium from this pseudostratified ciliated columnar. So the mucus secretions are produced from goblet cells of the epithelium. Mucus and serous glands of the lamina propria as well produce some. They contain mucin protein, which increases mucus viscosity and serves to trap dust, dirt, any matter floating in the air. We produce 1 to 2 tablespoons daily. If you are encountering more irritants, if you are a smoker or anything like that, that irritates your lungs. If you've been protesting and have gotten pepper sprayed, you're going to be producing more mucus and coughing things up more. Contains defenses against microbes, lysozymes, defensins, and immunoglobulin A. I will let you figure out which parts of the immune system these are part of. Are they part of innate or adaptive immunity? When you cough it up, it's called sputum. We have saliva and trapped substances in there. The nose is the first conducting structure for inhaled air when it comes in, unless you're breathing through your mouth. Formed by bone, hyaline cartilage, dense irregular connective tissue, and skin, so you got a little bit of everything in there. The bridge of the nose is formed by the paired nasal bones, a pair of lateral cartilages, and the alar cartilages, as well as the nostrils. I'm trying to flare my nostrils and I raise my eyebrows. The paired nares. Here you can see the nasal cavity with the concha, the ridges that help to disrupt the airflow, the oral cavity, as well as the pharynx, the three different regions of the pharynx. The nasal vestibule is just inside the nostrils. It's lined by skin and particle-trapping hairs called vibrissae. So those kind of larger hairs that you see in your nasal cavity, those are not cilia, those are vibrissae. The olfactory region is a superior part of the nasal cavity containing olfactory epithelium. Airborne molecules stimulate receptors for odor detection. Remember, kind of when you're smelling something, you can't just do a normal breath. Usually to get a really good smell of it, you have to take a deep breath in. It's because those olfactory receptors are higher up in the nasal vestibule. The respiratory region is lined by the pseudostratified ciliated columnar epithelium, an extensive vascular network, which is why nosebleeds are very common due to large just amount of superficial vessels in that area. Here is just a coronal section, sagittal and coronal. Your nasolacrimal ducts drain lacrimal secretions from the eyes, the nasal cavity. It helps to lacrimal secretions from the eye surfaces to the nasal cavity. It adds like a wash as well. The nasal cavity conditions the air, so it warms, cleanses, and humidifies the air. It's warmed by the extensive blood vessels. Remember, blood is transporting heat, so any air that's brought in, it gets warmed up. The mucus works to trap dust, dirt, and microbes. The cilia are going to sweep the mucus towards the pharynx to be swallowed or coughed out. Moist environment humidifies that air, so even if you're in the desert and you're breathing in air that is 0% humidity, by the time it gets into your lungs, it will be at about 100% humidity. And air turbulence is created by conchae, enhances all three processes. So the conchae, those ridges on the inside of the nasal cavity, are there to help disrupt the airflow. If you didn't have those and you just kind of breathe in air, it's kind of like when your nose is clogged and then finally it's unclogged and you take a breath and it kind of just hits you because it feels like it's coming in so fast. If those ridges weren't there, air would flow even faster and it wouldn't have time to be humidified and cooled and cleansed. A runny nose, rhinorrhea, it's a result of increased production of mucus from allergies or a virus, increased secretions from lacrimal glands, and exposure to cold air. You have water condensation and less effective cilia in the cold, so more products will stay, more mucus will stay. Okay, the paranasal sinuses. These are spaces within the skull bones. The sinuses is just a hole, it's just a space. They're each named for the specific bone in which they're housed, all connected by ducts to the nasal cavity. From superior to inferior, you have your frontal, ethmoidal. The sphenoidal are behind your ethmoidal, and then you have your maxilla. So it's like frontal, sphenoidal, ethmoidal behind you, and then your maxilla. Here's this. They're lined by pseudostratified ciliated columnar. Mucus gets swept to the pharynx to be swallowed or coughed out. You can see up there is the frontal ones. Just below those are the ethmoidal. Behind them are the sphenoidal. And then in your maxilla, if you kind of press along the side of the nose, that always feels really nice, kind of up along the frontal, the ridge right up here. It's because those sinuses are there, and when you press on them, you kind of change the pressure in your skull, and so it can relieve headaches. Sinus infections, sinus headaches, respiratory infection, or allergy can cause inflammation of the ducts that drain from the paranasal sinuses. So you have a decrease in mucus drainage, and it accumulates in your sinuses. Germs start to grow in the accumulated mucus, causing a sinus infection, and inflamed and blocked sinuses and pressure changes can cause sinus headaches. So it can actually, the ducts get inflamed, they stop draining mucus, that mucus accumulates, and the pressure increases, the bacterial content increases. Okay, moving into your pharynx, so going from the nose into the pharynx. I don't know why I always move that side. I don't like that side. Okay, the pharynx, it's a funnel-shaped passageway posterior to the nasal cavity, oral cavity, and larynx. It is your throat. It is when you swallow, when you have your mouth, you have your oral cavity, and then it moves right into your throat. Lateral walls composed of skeletal muscles partitioned into the naso, oro, and laryngopharynx. If you have gotten your COVID-19 test, I got one the other day, they go in through your nares, and you have to tilt your head way, way back because they reach all the way to the back of your nasal cavity. It's intense, it's deep. The nasopharynx is the most superior part of the pharynx, posterior to that nasal cavity and superior to the soft plate pseudostratified ciliate columnar epithelium. It's an air passage. It is not for food. You should not have food coming in. Sometimes food goes out, and it is uncomfortable. Soft palate elevates during swallowing to block food or drink. So it's not your uvula. Well, your uvula is part of your small palate, so it's kind of all elevating up to block food going up. It connects to the middle ear via the auditory or the eustachian tube. Opening allows for equalization of pressure on each side of the tympanic membrane of your ear. It contains your tonsils as well, and those are the pharyngeal tonsils. The tubal tonsils located near the auditory tube. We don't really talk about those. The pharyngeal tonsils on the posterior nasopharynx wall. When they become enlarged, because remember tonsils are there filtering inhaled and ingested material. We have inhaled material here, and when they become enlarged, they're called adenoids. So you might have heard someone say, "Oh yeah, I have adenoids. I'm having my adenoids removed." That happens. Moving down to the oropharynx is the middle region. It's posterior to the oral cavity, extends from the soft palate to the hyoid bone. So soft palate kind of is the posterior region of the top of your mouth. And then down to the hyoid bone is right above, kind of, if you have an Adam's apple, or if you can feel your laryngeal prominence, it's just above that. It's a passageway for both food and air. So it's not just food, or not just air. Lined by non-keratinized stratified squamous epithelium. This is going to be kind of living tissue. That's why you can get injuries and they heal very quickly in your mouth. They contain the tonsils, the palatine, and the lingual tonsils. The palatine on the back and the lingual at the base of the tongue. Moving even further, you have the laryngopharynx, is the most inferior region. It's posterior to the larynx, from the level of the hyoid down to the esophagus, food and air. And again, non-keratinized stratified squamous epithelium. There you go. You have your pharyngeal tonsils, your... Oh no, they didn't list any other ones. Okay, so you just have your pharyngeal tonsils on here. Okay, moving into the lower respiratory tract now. So this includes conducting pathways, SIL, from the larynx to the terminal bronchioles. Includes the structures involved in gas exchange, respiratory bronchioles, alveolar ducts, and alveoli. So the lower respiratory tract does include your respiratory structures, but we still are starting with conducting structures. The larynx is your voice box. It's the cylindrical pathway between the laryngopharynx and the trachea. So it functions as an air passageway. It prevents ingested materials from going into the respiratory tract. That epiglottis is covering the larynx when we swallow. And it produces sound for speech. The vocal cords, the vocal ligaments vibrate against air to produce sound. They kind of produce it, and then obviously the mouth refines. It assists in increasing pressure in the abdominal cavity. We call this the Valsalva maneuver. Essentially, it's for increasing pressure for urination, defecation, and childbirth. So if you have ever had to, if you have ever given birth, or if you have ever had to strain to defecate, you know that you can you don't think about the steps of it, but essentially you're closing down your esophagus, you're closing off your respiratory exit, and you're increasing your abdominal pressure. And so since the air can't go out, the pressure pushes down to help us bear down. And so that's the Valsalva maneuver. It participates in the sneeze and cough reflexes to help remove irritants from the nasal and lower respiratory tracts. Abdominal muscles contract to increase thoracic pressure. Vocal cords forcefully opened to expel pressure. An explosive blast of air is a cough or a sneeze, depending on where it comes out. Or how you do it, I guess. The laryngeal inlet, it connects the pharynx and the larynx. It's formed by 9 pieces of cartilage. We're not going to get into all of them. We do look at some of them, though. The single thyroid, cricoid, and epiglottis cartilages, those are definitely important. The pararytenoid, cartilage, we'll see those. That's more for lab. Okay, your thyroid cartilage, this is an important one. It's the large shield-shaped piece of cartilage right on the very top. It forms the lateral and anterior walls, and it has the laryngeal prominence. I don't like calling it the Adam's apple, I think I did earlier, but really it's the laryngeal prominence. It kind of comes out to a point right up here. You can kind of see it move when I swallow. It enlarges during puberty, testosterone. Yeah, you have the cricoid cartilage, which is just inferior to the thyroid cartilage, so just below the thyroid cartilage, that mantle there is a little small cricoid cartilage. And then at the top you have your epiglottis, which is spoon-shaped. It's anchored to the inner aspect of the thyroid cartilage. It projects upward and closes the laryngeal inlet during swallowing. So again, that inlet, that opening of larynx. You have the smaller paired ones, as well as some extrinsic and intrinsic ligaments that I'm not going to get super into because I am not going to ask you a whole lot about that. You should know hyaline cartilage, except the epiglottis, which is made of elastic cartilage. That's pretty important, just for structure and function reasons. So here are several views of the larynx. You can see the epiglottis in a couple of different views. This is that little flap. It will close down kind of this way. I'm not doing a very good job of that. It will close this way and cover this laryngeal inlet right here. This big shield piece is your thyroid cartilage. There's that laryngeal prominence right there. Just below it is the cricoid cartilage. And then you have these rings right here, which are all your tracheal rings. I think your book specifically calls those your tracheal cartilage, but I can't remember, to be honest. Your lab will have a word for that. But yeah, this is your trachea. So you have your larynx up here and your trachea down here, and these tracheal rings. Maybe I think that's what they call them, the tracheal rings, or each one of these. But the very first one, that first piece of cartilage below the larynx, laryngeal prominence, is the cricoid cartilage. Posterior, you can see the arytenoid cartilage and some of the other pieces. I'm not going to focus on those as much as I will the thyroid cartilage and the tracheal rings. Okay, the larynx anatomy, the vocal ligaments. So looking more at the vocal cords. They extend between the thyroid and arytenoid cartilages, composed of avascular, that's important, avascular elastic connective tissue. These are the vocal cords. They're kind of reverberating back and forth and need to have a lot of elastic tissue. They produce sound when the air passes over them or between them. The opening between the ligaments, the epiglottis, it's okay. You don't have to worry about that stuff. The vestibular ligaments extend from the thyroid cartilage to the arytenoid and corniculate. They're covered with mucosa that form the vestibular folds. These are actually your false vocal cords. So the vocal ligaments are the vocal cords, and the vestibular ligaments are your vestibular folds, false vocal cords. They play no role in sound protection, but they work to protect the vocal cords. So here you have your thyroid cartilage, that cricoid cartilage just below it. You have these vocal ligaments here. So this is when they are going to be closed, and this is when they are open, allowing sound. And then this is kind of what looks a little bit more, I guess, accurate representation of that. You still have these avascular, kind of whitish looking vestibular folds, vocal folds. And then just out to the side, you have these vestibular folds, which are protecting the vocal folds. Looking at the muscles, the extrinsic muscles stabilize the larynx and help move it during swallowing, originate from the hyoid bone or the sternum and insert on the thyroid cartilage. Your intrinsic muscles, skeletal muscles within the larynx, attached to the cartilages, contract and result to change in dimensions of the rhinoglottitis, involved in voice production and swallowing. So really, you should just know that extrinsic muscles are stabilizing and helping with swallowing. Intrinsic muscles are voice production and swallowing. So for sound production, we have to have vocal cord vibration. The intrinsic laryngeal muscles narrow the opening of the rhinoglottitis to force air past the vocal cords during expiration. Range is determined by the length and thickness of the vocal cords. Males have longer and thicker cords, so deeper voices. The folds increase in length with growth, deepening the range. The pitch is determined by the tension on the vocal cords. More tension, folds vibrate higher, a higher pitch, regulated by the intrinsic laryngeal muscles against the sound production. And then loudness, it depends on force of air passing across vocal cords. More air equals louder sound. A lot of times we will change our pitch to adjust and fluctuate with our emotions. Loudness as well, that's definitely something that we do. Well, I guess all of these will change with emotions. Pitch is one of those that's very commonly, the higher pitch you're talking, the more excited you are. I have a friend who she can't change the pitch. She's never been able to adjust the pitch of her voice. So when she's excited, she just gets louder, which you can imagine is really fun. But it's always very monotone. It never really goes up as an excited thing. It stays right at that same pitch, just gets louder. Laryngitis is inflammation of the larynx, hoarse voice, sore throat, sometimes a fever, caused by bacteria or viral infection or overuse, yelling or just talking. That's why this lecture is going to be 2 separate ones as opposed to just one 2-hour lecture where I'm talking the whole time. Severe cases can extend into the epiglottis, leading to a sudden airway obstruction, especially in children. If that epiglottis starts to swell and become inflamed, it can block the laryngeal inlet, reducing airflow. Okay, the trachea. Trachea is your windpipe. It's an open tube connecting the larynx to the main bronchi. I always kind of tell people that it's just a tube. It is just a cartilaginous tube. You can go to the pet store if you have a dog. You can go to or you don't have to have a dog to go to a pet store. But you can just get a trachea. You can get like a bull trachea, a cow trachea, whatever you want to, and you'll be able to see the rings, and you'll see it is just a hollow tube. It is anterior to the esophagus, posterior to part of the sternum. So it goes down to right about here, I guess, and then it starts to split. The tracheal cartilages support the anterior and lateral walls, not the posterior. These are C-shaped rings. These are not O-shaped rings. They're C-shaped rings, oh that's hard, of hyaline cartilages. They're ensheathed in perichondrium, dense fibrous membrane. They ensure the trachea is always open, and the rings are connected to each other above and below by ligaments. So the esophagus, if you remember, is a muscular tube that will collapse when there's no food in it, and then it opens back up and expands when food moves into it. The trachea always stays open. It has to constantly remain open, patent, if you will. And so the tracheal rings will help to keep it open and patent, but they're C-shaped, so they're flat on the back to allow the esophagus to expand and push up into it. The trachealis muscle and ligamentous membrane on the trachea's posterior surface. Really the big thing from this is, again, allowing for the accommodation of the esophagus. Trachealis contracts during coughing. That's good to know. The carina, this is important. It's an internal ridge at the inferior end of the trachea. So where the trachea splits into your main bronchi, you have this little internal projection called the carina that contains a lot of sensory receptors and initiates the cough reflex when irritants are present. So it's basically kind of, as you breathe air in, if something gets past all the cilia, doesn't get trapped in the mucus, all that kind of stuff, it can stimulate the carina. So before it actually goes into your lungs, you have a chance to cough it back out. Again, here is just a nice little representation of that. Right here at this split, that's where internally you'll have the carina. Again, you can see the esophagus posterior to the trachea. The trachea has this flat posterior portion where the rings don't fully connect, and so the esophagus can push up into it. Okay, now moving into the bronchial tree. The bronchial tree is a system of highly branched air passages. It originates at the main bronchi, branches to more narrow tubes, and ends in the small bronchial passageways. So for the most part, it's basically an extension of your trachea. It has some slight structural differences and physiological differences, mainly that these can start to dilate and constrict versus your trachea, which really doesn't. And we'll see how highly branched this gets. They split 16 to 17 times, the bronchi do. So the trachea splits into the right and left main bronchi, your primary bronchi, at level of the sternal angle. So kind of right around the sternum, they start to split. Each bronchus enters a lung on its medial surface through the hilum, which is just a hole in the lung that is kind of around, allows the bronchi to be continuous with the lungs, as opposed to letting them be kind of exposed and split. Anyway, each bronchus enters the medial side. The right bronchus is shorter, wider, and more vertically oriented. So foreign particles are more likely to lodge on the right side, the right bronchus, and we'll see it's because the right side is structurally a little different. Each main bronchus branches into lobar bronchi. We'll see that, we have main, primary, lobar, secondary, segmental, tertiary. I'm not really picky about the names. I like using primary, secondary, tertiary because that just makes a lot of sense to me. But you can use whichever one you want. The main bronchus branches into your secondary. Each extends into a lobe of the lung, smaller in diameter than the main bronchi, and we'll see that trend typically continuing as they divide. They go deeper and deeper into the lung tissue, and they get smaller. They further divide into these tertiary ones. It continues to divide into smaller passageways, and it leads to tubes. There are your bronchioles. They're smaller than 1 millimeter, leading to terminal bronchioles, which is the last part of the conducting zone, and respiratory bronchioles, which are the first part of the respiratory zone. So you have your primary, secondary, tertiary, lobar, segmental, whatever you want to call them, those first 3 main bronchi, and then we have these when we get to our bronchioles, then we have terminal bronchioles and respiratory bronchioles. The terminal bronchioles are going to be the last of the conducting zone, so that's going to be the last structure where its only function is really to transport air. Once we get to the respiratory bronchioles, this is when we start talking about exchanging gases. So here you can see kind of a breakdown of that. Again, these bronchioles are divided smaller and smaller, and they're dividing towards the alveoli. That's what they're going at. Again, you see, kind of lung tissue right here, but really you should just think, if you ever get to hold lungs, they're very squishy. They're very kind of like a sponge. It's because they're filled with these little sacs of alveoli. You can just see how it breaks down. Okay, bronchitis is inflammation of the bronchi caused by bacterial or viral infection. Acute or chronic, acute during or after an infection, coughing, sneezing, pain with inhalation, fever, usually 10 to 14 days. Not a huge deal. Chronic occurs after long-time irritant exposure, large amounts of mucus, coughing lasting for 3 months, permanent changes to the bronchi can occur, increases the likelihood of future bacterial infections. So the main bronchi supported by incomplete rings of the hyaline cartilage to help keep them open. The wall support lessens as the bronchioles divide, so as they get smaller and smaller, you lose some of this cartilage. The bronchioles actually have no cartilage, but a thicker layer of smooth muscle for bronchoconstriction and bronchodilation. So bronchoconstriction causes less air through the bronchial tree. Bronchodilation allows for more air through the bronchial tree. This is, again, just kind of breaking it down, smaller and smaller and smaller and smaller. Once you get down into the terminal bronchiole, again, that's the end of the conducting zone. You get into this respiratory bronchiole, and this is when we start to see really no cartilage and more smooth muscle. Asthma is episodes of bronchoconstriction, wheezing, coughing, shortness of breath, and excess mucus. Asthmatic with sensitivity to some type of airborne agent. Localized immune reaction occurs in the bronchi and bronchioles. The walls of the bronchi become permanently thickened. Steroids and bronchodilators can be treatments for it. Asthma can be really tough. I had it as a child. I actually have a friend who she lived in New York during 9/11, and she's still, this is 20 years later, she still has issues with asthma because of all of the dust that she had to inhale. So the respiratory zones, still in the respiratory zone, moving into the respiratory zone now. These structures are microscopic, so by the time you get to this point, you cannot see them with the naked eye. The respiratory bronchioles subdivide into alveolar ducts. The alveolar ducts lead to alveolar sacs, which are clusters of alveoli, and these are saccular outpocketings, which really could not tell you, I guess, more about what they do. But really, they are that simple. Alveoli are just, I always teach it, think like, if you take a piece of gum and you chew it up and you blow a bubble, you get this little air-filled sac, and it's really, really thin. You can see through it, but there's air in there. That's an alveoli. It is just an air-filled sac that is really thin to allow for gas exchange. So at the epithelium of the respiratory system, the bronchioles lined with simple cuboidal, alveoli and alveolar ducts with simple squamous. That thinness is going to facilitate this gas exchange. So here you can see the branch of the pulmonary arteries coming in to be oxygenated. Here's your bronchiole that is bringing in fresh air. They're going to kind of intertwine and wrap around these alveoli, these sacs of alveoli right here. And you can kind of see in those alveolar pores where they'll connect, those will join back into the bronchiole. Each lung contains 300 to 400 million alveoli. The pores are openings providing collateral ventilation, supporting pulmonary capillary, surrounded by pulmonary capillaries. Again, those are going to be deoxygenated, trying to become oxygenated, offloading their carbon dioxide into the alveoli, which can then exhale that carbon dioxide out. Divided by the interalveolar septum with elastic fibers, there's a lot of constriction or shrinking and expanding that happens here. Different types of cells in the alveolar cell wall. The type 1 cells are the most common of the two cell types, making up the alveolar wall, 95% of the surface area, and form the alveolar epithelium of the respiratory membrane. We'll talk about the respiratory membrane when we get into that. The type 2 cells are your septal cells. They're going to secrete the pulmonary surfactant, important function for them. This coats the inside of the alveolus and opposes collapse during expiration. So when you exhale, the alveoli are losing that air, the tendency could be for them to just collapse in on themselves. So the pulmonary surfactant helps to keep them inflated and keep them open, which makes breathing easier for us. The alveolar macrophage, dust cells, leukocytes that engulf microorganisms, they're macrophages. They are fixed or allowed to migrate, and they clean things up. They eat pathogens. Okay, so looking at this respiratory membrane, this is where the gas exchange will actually occur. You have oxygen coming from the bronchioles and the terminal bronchioles into the alveoli, diffusing into the bloodstream, while carbon dioxide from the bloodstream is diffusing into the alveoli. The respiratory membrane, it's a thin barrier separating air in the alveoli and blood in the pulmonary capillaries. You have your alveolar epithelium and its basement membrane, the capillary epithelium and its basement membrane, and these two are fused. Okay, so it's not super intense. You have an alveolar capillary epithelium connected by their basement membranes. Oxygen from alveolus to the capillaries, erythrocytes become oxygenated to get back to the heart on pulmonary veins. Carbon dioxide diffuses from blood into the alveolus, exhaled into external environment. So here you can see kind of the respiratory membrane in action if you want to. This is your alveolus. Here's your alveolar membrane. Here is your capillary membrane, or epithelium, sorry, your alveolar epithelium, your capillary epithelium. They're connected by their basement membranes, and oxygen and carbon dioxide can diffuse right across fairly readily, very easily. Okay, looking at the position of the lungs, you have the heart. Oh, I should move this side. You have the heart that sits right in the mediastinum. This is your cardiac notch of the left lung, where the heart actually points a little bit to the left. The right lung is larger and wider than the left lung. It has 3 lobes divided by 2 fissures. The horizontal separates the upper and lower lobes. The horizontal separates the superior from the middle lobe, and the oblique fissure separates the middle from the inferior lobe. The left is smaller than the right because of the heart's position. It has 2 lobes divided by just 1 oblique fissure. The cardiac compression and the cardiac notch are there to accommodate the heart and the aorta. Here you can see those. And they're right versus your left. Right with its 3 lobes. There's the horizontal fissure. There's the oblique fissure mirroring the left side, again running obliquely. And you can see how the vessels go in. Again, this is what I was saying about the hilum of the lungs. It's not really a hole. It's more of a passageway that is lined with connective tissue that becomes continuous with the coverings of the lungs and the coverings of the vessels. So it never actually opens to the pleural cavity. Each lung has multiple bronchopulmonary segments, 10 in the right, 8 to 10 in the left. These are autonomous units encapsulated with connective tissue, each supplied by its own segmental bronchus, supplied with its own pulmonary artery, vein, and lymph vessel that can be removed individually in cases of diseases. And each of those segments is organized into lobules, supplied by a terminal bronchiole, arterial, venule, and lymph vessel. So it's essentially just saying that we can break our lungs down into smaller and smaller portions, yeah. We can break our lungs down into smaller and smaller sections, and each of these is going to be completely autonomous. So if this portion of your lung is diseased, you could remove that one portion, and in theory, the rest of it would still function perfectly fine, because each portion is going to be supplied by its own, have its own vascular and respiratory supply. Smoking causes respiratory changes with increased chance of respiratory infections, genetic changes to the lungs, emphysema, cancer, ulcers, atherosclerosis, lower birth weight, poor delivery of oxygen, bronchitis. Honestly, if you don't know that smoking is bad for you at this point, you're just trying to ignore it. All right, so sorry, I grew up with smokers, so I have, not a whole lot of sympathy for not understanding the harmful effects of it. Blood supply, two types of circulation in the lungs, pulmonary circulation and bronchial circulation. The pulmonary circulation is going to be replenishing oxygen and eliminating carbon dioxide. Pulmonary arteries carrying deoxygenated blood to the pulmonary capillaries, blood allowing to be reoxygenated, then pulmonary blood, that oxygenated blood going back to pulmonary venules, back into circulation. We learned that. You should know that. Bronchial circulation, this is similar to the coronary circulation. The lungs need their own fresh blood supply as well, just like the heart needs its own fresh blood supply. So bronchial circulation is transporting oxygenated blood to the tissues of the lungs. You have bronchial arteries, because they're moving away from the heart, branching off of the aorta, the descending aorta, and bronchial veins collecting venous blood. And this is where it starts to get a little interesting. It actually drains into the pulmonary veins. So you have this slight mixture of deoxygenated blood being mixed back into your freshly oxygenated blood that's traveling back on the pulmonary veins. So this is just a lovely, confusing little picture, I'm sure. But essentially, you know what's happening. You have deoxygenated blood leaving your heart, going to your lungs, gas exchanges occurring, as well as your lungs are being oxygenated with fresh blood from the pulmonary, from bronchial arteries. And then all of that is going to be joining back into the pulmonary veins to go into the left atrium. With overall, that will have oxygenated blood. But again, there is a small portion of deoxygenated blood that gets mixed in. Lung cancer is highly aggressive malignancy with early metastasis. Think about all of the everything that your lung comes into contact with. It can easily metastasize. Originates in the respiratory epithelium. 85% of the cases are caused by smoking, chronic cough, coughing up blood, pulmonary mucus, pulmonary infections. Three basic patterns. The squamous cell carcinoma, this is the most common, from the pseudostratified columnar epithelium. Changes in that to withstand chronic injury. So as you're smoking, you're constantly injuring that epithelium, and so eventually it just starts to become thicker and harder. Adenocarcinoma arises from mucin-producing glands, and small cell carcinoma from neuroendocrine cells. Okay, talking about lymph drainage. So we did mention that there were lymph vessels as well in this respiratory tract. So lymph vessels and nodes are located within the lungs' connective tissue, around the bronchi, and in the pleura. We'll talk about the membranes of the lungs. They are important in removing excess fluid from the lungs, so it doesn't just sit there. That can easily cause infection, difficulties breathing. Lymph is filtered through your lymph nodes, and it collects particles and pollutants not removed by cilia. So it is still, it's lymph. It's lymph nodes doing exactly what we learned. Spent a whole chapter learning. All right, innervation of the respiratory system. So how do we actually regulate our breathing? It's one of those unique systems where it is under autonomic control. You don't have to think about breathing. You don't have to be conscious. Your body will do it on its own, but we can step in and create conscious control. So the autonomic nervous system innervates the smooth muscles and glands of the respiratory structures. Sympathetic output from T1 to T5, about like T1 is about even with your neck. T5 is about there. Sympathetic output from those causes bronchodilation. Sympathetic output, bronchodilation. Sympathetic output opens the airways, increases air intake. Parasympathetic from the vagus nerve causes bronchoconstriction. It then signals to the larynx. Pleural membranes and pleural cavity. That was very, very straightforward, I know. So the pleural membranes and pleural cavity. The pleura is a serous membrane lining the lung surfaces and the thoracic wall. So there are different membranes all throughout your body. In your lungs, we call them the pleural membranes. In your abdomen, it's the abdominopelvic membrane. For your heart, it's in your mediastinum is what we call it. So the pleural membrane is just the membrane that contains your your lungs. And the pleural cavity is just the hole, the space rather, that your lung sits in. You have two pleural cavities because they are separate from each other. It's composed of simple squamous epithelium. You have a visceral and parietal pleura. The visceral pleura is going to adhere to the lung surface. Viscera, visceral lung. Where we did this when we did the pericardium of the heart. The parietal pleura lines the thoracic walls, the lateral surface of the mediastinum, and the superior surface of the diaphragm. So this is going to basically be lining the actual cavity itself. So you have the visceral pleura right around your lung. You have your parietal pleura that lines the lateral half of the mediastinum, the cavity for your heart, the thoracic walls, and then the superior portion of your diaphragm, which is that respiratory muscle that's going to pull down and help you breathe. So each lung is enclosed in a separate visceral pleural membrane to help limit the spread of infections. Right? It makes sense. As you have things in small cavities, you can limit the spread of bacteria and any kind of fluid or infectious agents. The pleural cavity is located between the visceral and parietal serous membranes. So this is the space, right? So this is the space between those two membranes. A serous membrane is just an internal mucous membrane. So it's basically a mucous membrane that's just inside rather than exposed to the environment, like your nasal cavity or your mouth, or some of your genital cavities. When the lungs are inflated, it's considered a potential space. So when you inhale, your lungs fill up and they close that potential space. There is no space in the pleural cavity. The serous fluid, when you exhale, there becomes slightly more space. The serous fluid is produced by serous membranes. Makes sense. Mucous membranes produce mucus. Serous membranes produce serous fluid. It covers the pleural cavity surface. It lubricates, allowing those pleural surfaces to slide over each other easily. Each pleural cavity has less than 15 mils of fluid, and it's continuously drained by lymph. If this starts to get backed up and starts to fill up, it can be very bad for breathing. Pleurisy is an inflammation of the pleural membranes. Severe chest pain when breathing, inflamed membranes increase friction between the pleural membranes. Usually only one side is affected because they are independent of each other. Pleural effusion is excess fluid in the pleural cavity, causing shortness of breath, chest pain. Potential causes, systemic factors. It could be left side heart failure, pulmonary embolism, cirrhosis of the liver, lung infections, or lung cancer can all be options. So now looking at how the lungs remain inflated. Those membranes are actually very important for maintaining the lungs patent and for breathing. So the intrapleural pressure between the membranes is low. So the intrapleural, between the pleural membranes, that pressure is incredibly low. The chest wall is configured to expand out. If you do chest surgery, when they open up the chest cavity, the lungs will kind of expand and pop out. The lungs cling to the chest wall due to serous fluid surface tension, and the elastic tissue of the lungs pulls it inward. So you have these kind of opposing forces of this serous fluid that's trying to hold the lungs open, while the elastic tissue of the lungs tries to pull them back in. Because the intrapulmonary pressure now in the alveoli is greater than the intrapleural pressure, the lungs remain inflated. So the lungs experience this outward pull from the chest wall. So what you have happening, and this starts to get a little tough for people because we're talking about different pressures, and I think there's a diagram coming up, but I'm going to try to explain it first, is that you have your intrapleural pressure between those two membranes, the one that's on the visceral membrane on the lung, and then the parietal membrane that's on the thoracic cavity. In between those two, there's this intrapleural pressure, and it's low, so it's not very high. But then you have this high intrapulmonary pressure, which is pushing out. So this is inside the alveoli in the lungs. If that is higher than the intrapleural pressure between those membranes, then it's going to be pushing your lungs out. At the same time, though, you have these other forces. You have the elastic elastic pull of the lungs trying to draw them inward. You have the serous fluid that's trying to pull them outward. You have the configuration of the chest wall that wants to expand outward. So you have these opposing pressures that are keeping the lungs inflated, but also making sure they don't just, blow up. So you have in your lung that intrapulmonary pressure, the pleural cavity with its intrapleural pressure, and then this is going to be your thoracic wall that it's kind of glued to and holding itself to. Okay, pneumothorax, air in the pleural cavity. Air is introduced externally, penetrating wound to the chest. It could be introduced internally, a rib lacerating the lung or alveolus ruptures. It may cause the interpleural and intrapulmonary pressures to equalize. So instead of the interpulmonary being greater than the interpleural, these can start to equalize. When that happens, small ones resolve spontaneously. Large ones need a medical emergency. You have to insert a tube into the pleural space to remove that air. So essentially what's happening is that you have air going into that pleural cavity. And as air builds up inside this pleural cavity, it will start to push against the intrapulmonary pressure, and they'll eventually if the wound is large enough, they'll start to equalize. Maybe I'll do it this way. They'll start to equalize and balance out, and then your lungs can collapse. So if you've ever seen someone when they're like, oh my gosh, like they're, something's wrong, they're not breathing, and they listen to their lungs and they don't hear any lung sounds, and they take a needle and they just stab it into their chest, that's there to help release the air pressure release the air that is developing in this pleural cavity. What they don't show you is that you have to redo that, especially because it's always in an emergency when that happens. They do it and then they never talk about it again. Every 30 minutes or so, you will have to go in there if you don't actually fix it. You have to go in there and you have to basically re-release that pressure because it will start to build up again. Hopefully you never have to do that just in that kind of emergent sense. Hopefully if it ever happens, you are in a clinical setting and are trained to handle it. Atelectasis, there we go. Atelectasis is a collapsed lung, occurs if intrapleural and intrapulmonary pressures equalize due to air in that pleural cavity. It will remain collapsed until the air is removed from the pleural space. Once that air starts to get removed from the pleural space, the pleural cavity, then the lungs, the intrapulmonary pressure can start to overcome the intrapleural pressure and reinflate. Okay, and that's actually where I'm stopping with this lecture.